statistically significant. So in red you see the curve for CTA alone, and in white you see the curve showing the incremental value in terms of area under the curve of the CT perfusion study. How to use this? Well, if you want to use it as a screening test, then any perfusion defect being considered abnormal, then the sensitivity is extremely high, the negative predicted value is extremely high. But if you want to use it more as a diagnostic tool, then you can choose, for example, some stress score of 4 to be similar to SPECT, for example, and then the sensitivity is 82, specificity is 73, and the negative predicted value is still quite high. Now, what about patients without history of CAD? If you take only the group of patients without known CAD, then the area under the curve is 0.93. So it's an extremely powerful test. And now, if you use the same, a similar table, sensitivity and specificity is 80%. If you use a sum stress score of 4, and you still have a negative predicted value of 92 of excluding a flow-limiting stenosis. I like to highlight flow-limiting because this is not only an anatomic measure, it's the anatomy corresponding to a perfusion defect. Now, finally, looking at the reference standard here of patients who went to revascularization, both the combination of ICA and SPECT in gold and CTA, CTP in white were able to differentiate or to predict quite well those patients who went to revascularization, if you analyze it by patient or if you analyze it by vessel. And finally, in terms of radiation, I show here radiation for the calcium score, for the CTA, for the CTP. In total, the CT study, the radiation in terms of millisieverts was 9.3, and for the SPECT study was 9.7. So in summary, combined CTA and CTP can detect hemodynamically significant stenosis by invasive coronary angiography with an associated SPECT MPI defect. CT myocardial perfusion adds to the diagnostic power of CT angiography alone, and the combination of CT angiography and CT perfusion in one non-invasive examination is useful to identify patients who benefit from revascularization and therefore to guide management of CAD. In conclusion, ladies and gentlemen, in patients with suspected CAD, the combination of CT angiography and perfusion correctly identifies patients with flow-limiting obstructive coronary artery disease. Thank you.
Thank you, Dr. Lima. We now move